Hello and welcome everybody. Again, my name is Patrick Kenney, for those who don't know me. First year fellow here at the University of South Florida, Morsani College of Medicine. Let me see it here. So just to move the slides, Doctor, Ayler, how do I just hit this? Okay. Okay, so the reason why I chose this topic is because so many of our patients are HIV positive, and we are not only infectious disease specialists, but we're also internists, and for many of our patients, we are their sole provider, and it's important for us to always stay refreshed with the current guidelines as far as the primary care aspects. So this is just a map for it's a couple years old, showing the rates of new HIV infections here in the United States. And as you can see, in the southeast, Georgia and Florida are among the main, among the highest in incidence, and as well Puerto Rico and the U.S. Virgin Islands as well. But across the country, there still is quite a bit of a problem with new infections. I'm uncertain why the West Coast wasn't reported here, but it wasn't a bit. Perhaps they didn't participate. Again, reiterating the fact that why do we need to be aware of the primary care issues is because we have so many patients living in Florida with HIV. If you look just in Florida alone, so concentrated here, as well as in New York and Texas, all along the border states. We need to, so this is very important for us to be well versed in these issues. AIDS and death cases in the United States from 1985-2004. As you can see, before the advent of HAART, you can see that the number of deaths related to AIDS was increasing, and then HAART came along and deaths started to decrease. However, this is just reading the fact that our patients are living longer, and subsequently, what happens with these patients? Why do we need to? What issues do we need to look at in the aging patient with HIV? So. As we can see from the MAX study, higher viral loads lead to an advanced development of AIDS. So it used to be that many of the patients who were diagnosed back in the 80s and early 90s they died quickly from complications from AIDS because of advanced viremia and further complications. So as you can see, with a PCR greater than 55,000, it was more 89% had a CD4 count less than 200, so clinical AIDS. So some of the things we worry about obviously are, of course, opportunistic infections, and that's what the main reason why HIV has kind of revolutionized the infectious disease field, because of the advent of all these infections and the need to treat them. So I use the Florida Caribbean AETC pamphlet to help me out here and talk about some of the opportunistic infections that we see in HIV and AIDS. Again, things we look out for with CD4 counts 200 to 500, pneumococcal and other bacterial pneumonias, tuberculosis at any CD4 count, zoster, oral candidiasis, and Kaposi sarcoma. And less than 200, we worry about the increased risk for pneumocystis, disseminated histoplasmosis and coccidiomycosis, miliary TB, as well as progressive multifocal leukoencephalopathy, or PML. Less than 100, then we start worrying about more disseminated infections, disseminated herpes, toxoplasmosis, cryptosporidiosis, and less than 50, we start seeing even more disseminated viral diseases, disseminated CMV, as well as disseminated MAC. So we have these things that you'll see, herpes zoster, candidiasis. You'll see more pneumonias. You'll see tuberculosis. Um, you'll see also we have to worry about HPV and anal as well as cervical cancers, and then CMV retinitis and toxoplasmosis. So again, most of us already know this already, but it's just a refresher that we like to prophylax our patients when it's appropriate. For PCP prophylaxis, T cell count less than 200 or a CD4 count less than CD4 percentage less than 14%. Or with a history of oral candidiasis. Again, the preferred drug is Bactrim or trimethoprim sulfadoxazole. And again, toxoplasmosis, we like to prophylax when the CD4 count's less than 100. And we check the toxoplasma IgG, and if the patient has a toxoplasma IgG, again, Bactrim 1 pill once a day. And we also prophylax against disseminated mycobacterium, avium complex, with a CD4 count less than 50. And we like to use the drug of choice, azithromycin, 1,200 milligrams per week, and the other regimens are there. So again, the primary aspect of this talk is talk about the non-AIDS complications, some of the the medical issues that we see. We talked about cardiovascular disease and HIV. So what is it about the cardiovascular disease and HIV that that poses risk? Well, the HIV infected patient, they're aging. They have just aging alone. And having subsequent risk factors, having HIV makes it even more of a risk factor. They have, and they're also on medications that can also increase their risk for cardiovascular disease as well. And HIV populations have more cardiovascular risk factors than their contemporaries and their peers who are the same age who are uninfected. So some of the risk factors that are, risk factors that can't change: gender, mostly male, family history, prior history of cardiovascular disease, and age. Things that we can help our patients change about their habits to help decrease their risk: tobacco use, getting control of their blood pressure, keeping them at a healthy weight, if they have, preventing them from diabetes or controlling their diabetes, and then monitoring their lipids. And that's something we're going to talk about later. Try having an elevated LDL, lower HDL, and increased triglycerides. And unfortunately, in our effort to treat their HIV, we more often than not can affect their lipids in a negative way. So again, this shows the relative risk of increased heart disease, ischemic heart disease with HIV infection. So if you could see patients who are not on antivirals, that the risk is 1.4, the relative risk is 1.4, and then it seems while being on retroviral therapy, it increases some, but then the first 90 days, however, seems to be a very high relative risk for ischemic heart disease, and we'll talk about that a little bit later. And then when you adjust the relative risk for the after the first 90 days, you're 2 times more likely to have to have heart disease. And some other risk factors in the HIV-infected population from the DAD study. Smoking was huge. A huge risk factor. Have elevated having baseline elevated lipids and low HDL were again big risk factors for the patients. Again, this graph just shows that our HIV positive patients have a higher incidence of metabolic syndrome, elevated blood pressure, dyslipidemia, and diabetes. And if you compare HIV negative patients to HIV positive patients on heart, you can see the yellow line shows that they have more as the duration of those patients who are on heart tend to have higher risks of cardiovascular disease than those that are not on heart. And again, basically showing more risk factors. If you're on antiretroviral therapy and you have a prior history of smoking, you have very high risk, and then of course your risk increases with increasing age, use of retroviral therapy, male gender, and smoking. This slide again just shows that HIV positive patients are much higher risk for metabolic syndrome, and you can see the various components of that. They all higher than the HIV negative. So why are these patients having such higher risk? There are two schools of thought. One being is medication-induced, other being HIV being a chronic state of inflammation, and but we can see that from data that antiretroviral therapy can have an effect on the cardiovascular system with like medication induced by by protease inhibitors, and you can see that as the number of protease inhibitors and the number of years, and the number of MIs per 1,000 patient years goes up. So again, the slide tells you that the antiretroviral therapy, there is an increased risk for MI as found from the DAD study. There was, however, an adjustment done. The adjustment basically said that lipids, the adjustment for lipids largely explains the decline in MI. However, protease exposure is associated with a similar increased risk of heart exposure. And NRTI exposure was not associated with increased risk for MI. And basically, the study suggested that the increased risk was previously reported with heart largely driven by PIs. As you can see, this was the data with all antiretroviral therapy. With PIs, it was merely the same, and NRTI was significantly less. Again, from the DAD study, we could see that basically the DAD study was showing that what were the adverse events that antiretroviral therapy brought about, and they saw that there was overall an increased risk for MI, and Kaiser Permanente did a study showing that there was HIV was an independent predictor of a composite outcome, death or repeat revascularization. A lot of the patients were coming in with coronary disease, and they were trying to decide, well, if medication's part of it, what about this chronic inflammation? And there were a couple of articles that were found about HIV protein-associated inflammation, low CD4 associated with subclinical carotid stenosis, the elevation of endothelial-derived markers, the CAMs, as well as increase in interleukins. Okay, so we'll talk about lipids, as we were talking about earlier. Lipids, basically, many of our patients that are on antiretroviral therapy have dyslipidemia, and if you can see that the total cholesterol in patients who are naive, as you start adding agents, it gets progressively worse. And as you can see in protease inhibitors, many of these patients have elevated total cholesterol, elevated LDL with decreased HDL. Mostly when they're on NRTI, PI, and NRTI. And basically this graph basically shows that this cohort view of lipid changes before and after seroconversion. So patients who were negative had their cholesterols measured, and then when they started HART, they started seeing a steady rise, and after being on HART for 3 years, they saw an elevation in the total cholesterol and LDL. However, HDL pretty much remained low consistently even before and after seroconversion. So like I said earlier, the protease inhibitors, they basically have the greatest impact on lipids. They don't really affect the HDL much. However, atazanavir or Rayataz has the least effect on serum lipid levels among the available PIs now, and is pretty much has been chosen as its therapy of choice when a protease inhibitor is preferred for HIV therapy when a patient has increased risk factors. And abnormal lipids may be improved in switching a patient from to atazanavir from another PI. So it's something to keep in mind. Now, this slide shows, unfortunately, that with when we boost atazanavir, we do lose that lipid-sparing effect, and as you can see, we don't. Sorry. The change from the baseline at week 48, you see a big difference when you add ritonavir, but you don't see the change when it comes to HDL and triglycerides. All right, so NNRTIs have a more favorable impact on lipids than the protease inhibitors. Efavirenz, however, is shown to increase triglycerides more so than atazanavir, and nevirapine has the most favorable impact on lipids in the class, and it's shown to improve HDL in some compared to pretreatment levels. So if the patient has, if the estimated cardiac risk, or the Framingham equation, is significant relative to compared risks for AIDS, first you want to have the patient make sure they stop smoking. So they're low risk. You want them to stop smoking, increase their exercise, get their blood pressure under control, control their diabetes. If they have elevated cholesterol, you want to switch their you can switch their intravalvular therapy, or you can start a statin. We're going to talk about those in a minute. Elevated triglycerides, we can start fibrinic acid derivatives, and or switch their antiretroviral therapy. And if they have low HDL, you can put them on a statin, or put them on a fibrinic acid derivative, or you can use fish oils as well. Pravastatin was the statin that showed a lot of promise with associated diet changes which improved PI-associated hypercholesterolemia. And as you can see here, it's hard to see. It's hard to see on the screen. However, you can see that the lipid levels did improve markedly with adding pravastatin and weight loss. But however, there weren't any changes in triglycerides. And niacin is also a good supplement in using antiretroviral therapy. It helps improve HDL, and it's been seen here as well. Some of our patients are on multiple medications, and that run through the cytochrome P450 system. So fibrinic acid derivatives, such as fenofibrate, gemfibrozil, they can have interactions with statins, so you can have increased muscle breakdown, increased risk for rhabdo. So fish oils have been shown to have an effective decrease in triglyceride levels. And again, we want to show, going back to drug interactions, we can see that the fibrates and pravastatin had a low interaction potential whereas the statin and fibrate combination with Lipitor or torvastatin, just be careful and watch these patients a little bit more cautiously when you interview them. And then lovastatin and simvastatin are contraindicated with PIs, so keep that in mind. So basically, there is a role in lipid lowering agents for people with dyslipidemia and HIV, but you really have to target the lipid levels and you really have to watch the costs. You have to watch the pill burden, and because once patients start getting too many pills, then they really don't. It could lead to them not taking their HIV medications, which is the ultimate goal of suppressing the virus. And then we want to watch the drug-to-drug interactions. Diabetes, again, another big problem with our patients. Basically, this graph just shows among all age groups, even HIV negative, you're still going to see a steady increase in the incidence of, until we get to the age of 65, of diabetes. However, it's markedly increased in patients with HIV. And some of the pathophysiology of insulin resistance, you have your classic risk factors being obesity, physical activity, genetic predisposition, older age, and dyslipidemia. But also you have the HIV on top of it. You have the lipoatrophy that can also lead to increased liver or muscle fat, lots of inflammatory cytokines, low testosterone, and then oxidative stress from this inflammation. Also, hepatitis C infection and protease inhibitors can also add to insulin resistance. So again, potential causes directly from antiretroviral therapy. Some of these medications impair the cellular glucose uptake of PIs. They also PIs can also inhibit the glucose transporter cell, the GLUC4 receptor, and PIs may also decrease the glucose sensitivity, but it has not been seen in atazanavir and fosamprenavir. Some of the indirect effects, again, like I said earlier, the body fat changes that we see, lipodystrophy and lipohypertrophy. A lot of these patients will have increase in central obesity and fat deposition in the liver and muscles. And then also niacin, even though it was great for helping lower HDL, it also led to indirectly to some insulin resistance in treating dyslipidemia from antiretroviral therapy. And these are basically just this is a quick slide just showing some of the medication, some of the medications and their relative risk for causing diabetes. Some of the older medications here. This is more just showing the incidence of metabolic syndrome is lower in patients with taking atazanavir. Lipodystrophy. Basically, it's a pretty broad term, basically just showing that the change in body fat as a result of medication. And lipoatrophy we see in some of our patients who have wasting in the face, the upper extremities, and the truncal subcutaneous fat. Some literature describe it as roping. Because you could see the veins on the arms and legs. Lipohypertrophy. Basically just fat accumulation in the abdomen, breast, and anterior posterior neck, the classic buffalo hump. Some patients have both or or just one of these. And some of these syndromes, they have these syndromes have distinct risk factors, overlapping pathogenic factors and different long-term implications, but the changes in body fat distribution are associated with, like I said earlier, the metabolic alterations, namely alteration in glucose and lipid metabolism. And these are just some of the features that you might see: the atrophy from the face, the loss of subcutaneous fat in the lower extremity, with this roping effect. You can see seeing the vasculature, and then again with lipohypertrophy, you can see the accumulation of central fat, and the classic buffalo hump seen here. Some of the factors that promote fat distribution and NRTIs, PIs, basically several of the classes of antiretroviral therapy, age, gender, being Caucasian, poor nutrition, and having multiple other comorbidities and having a genetic susceptibility for that. Lipohypertrophy, if the patient was obese to begin with, they are at higher risk for that. Again, being on PIs and advanced age, and again, genetic susceptibility. The drugs that are the greatest risk for lipohypertrophy are the NRTIs, especially those containing thymidine, so those listed here, efavirenz, as well as the PIs listed here as well. For lipohypertrophy, basically any PI used for greater than 22 months, or you're going to see an increased risk. There is also a risk even seeing it in less than 22 months as well, but it's not as much. And this basically, the slide just shows graphically the increased risk of lipohypertrophy over in efavirenz versus lopinavir, as you can see here. And again, the impact of body fat distribution on patient anxiety, depression, and quality of life. These patients are going to be coming to you. They're going to be depending on their demographic, and where they're coming from. They're going to be, they're afraid of stigma, and the stigma can lead to anxiety, fear of rejection from relationships. People don't want to have people don't want to come up to them because they have they know that they have these characteristic look from being on HIV medication. So it's something to look out for and ask your patients about. And there are some therapies for lipohypertrophy. So with recombinant growth hormone. Again, and growth hormone releasing factors, and also actually liposuction of the buffalo hump themselves. So you can actually see, you can actually see all decreases visceral fat. However, there are several disadvantages that. Increasing insulin resistance and more lipoatrophy. So you have to pick the right treatment for your patient if that's the case. Again, osteopenia and osteoporosis in HIV. Early osteopenia and osteoporosis are seen in HIV, but they're linked to the disease and treatment. And some cohort studies have shown that up to 54% of HIV patients, osteoporosis was found in 13% via DEXA scan. So, risk factors for bone mineral abnormalities, having a BMI, white ethnicity, alcohol use, having low CD4, and the amount of time actually on tenofovir had a high odds ratio there. But the only one that was really significant was BMI. Higher BMI. Excuse me, thank you. So basically, how do you assess these patients? Well, you DEXA scanning and treating patients with calcium and vitamin D supplements, having them do weight-bearing exercises. You could check these patients' hormonal status. You can do testosterone or estrogen replacement therapy, and encourage them to quit smoking and drinking alcohol. Again, and then HIV also has its affiliations with renal disease, with basically HIV-associated nephropathy, glomerulonephritis, and thrombotic disease. And this is just a picture showing some of the collapsing focal segmental glomerulonephritis. There's also HIV-associated neurocognitive effects. That basically from vascular dementia, HIV-associated dementia, and then some neurocognitive impairment. this is basically for the podcast purposes, going over some of the antiretroviral therapy that are available for patients, from the latest guidelines, and basically we can talk about, very cursory, how the HIV medications work and where their effects are here. As you can see, you have your entry inhibitors working at the start of when HIV binds to the CD4 cell. Then you have your non-nukes and nukes working there, and then you have your integrase inhibitors working in the nucleus of the CD4 cell, and then your protease inhibitors working to prevent further budding of the virus out. And the DHS guidelines when to start HAART. We start, less than 350, 350 to 500, greater than 500. This is a very controversial subject. So, and we have the START study now that is a randomized control study to see if whether starting patients greater than 500 is beneficial versus waiting till they get to less than 350, and that data is still forthcoming. Again, this is just the list of medications. I'm not going to go over all of these, but these are for for your information. And the preferred regimens, as the NNRTI based with efavirenz, tenofovir, and emtricitabine, also known as Atripla. You also have your PI based regimens with boosted darunavir or atazanavir, with Truvada or tenofovir and emtricitabine, and you also have your Camivir and Kaletra regimen for pregnant patients, and our integrase inhibitor based regimens. And then these are some alternate regimens. If your patients have renal disease, you might want to use if they have renal problems, you can use abacavir and 3-TC as well, with combinations described earlier. So, this slide was formatted differently. However, basically it's just showing factors that lead to non-compliance. Basically, you're not going to start someone who's not ready to take their medicine. If they have potential for adverse drug events, if they have pregnancy potential, you have to worry about all these things, and then you have to also look at the results of their genotype resistance testing. Make sure you put them on the right medicine. Because that could, you get the patient says, I'm taking my medicine, it's not working. You think they're non-compliant, but really they're resistant and you didn't look at it. So you gotta watch out for that. And then if they have other comorbid problems like TB, liver disease, mental illness. And again, basically just going back to the DAD study again, you want to really be careful when selecting your medications. The DAD study did show that abacavir showed the increased risk of MI compared to the other NRTIs. However, the tenofovir data was not included in the initial analysis, but was added later. All right, so some of the liver effects of the antiretrovirals. Basically, the NNRTIs had the largest incidence with virapene, but it's usually associated with hypersensitivity rash. Women were at higher risk for having this problem. The higher the CD4 count was, higher the risk. So you don't want to ever use this nevirapine with post-exposure prophylaxis. And lactic acidosis was seen in some of the older medications, and again, increased risk of being female and being obese. And then osteopenia, as I said earlier, many of the medications showed increased risk for osteopenia and osteoporosis, but the risk may be higher in tenofovir. And then this is again showing what will happen with poor, what will lead to poor adherence to medications. The stigma, low literacy, treatment fatigue. Starting someone very early, they just don't want to. They just stop taking it for many reasons. So if they're a substance abuser, and then if they're having physical difficulty taking the pills, swallowing, or if they have a busy schedule. So you have to be cognizant of that. Again, these slides pretty much show the adverse effects of the medications, but we've gone over many of these already. So, in the benefit of time, I will. But the big one I want to show is efavirenz. We see, because as I said before, efavirenz is one of the top medications used, one of the preferred medications with Truvada. We do want you see a lot of patients with the neuropsychiatric effects, mostly vivid dreams. So you got to tell your patients about that, and any of your patients or your childbearing females, you don't want to have them on efavirenz. Unless they have, unless they vow to you they're not going to get pregnant, but I would avoid if possible. And then it has an increased risk for dyslipidemia. Again, this is going into some of the adverse effects, and a lot of this you see you'll be looking up anyway. Let's see here. So some of the screening guidelines for our patients. Why should we screen these patients more? We shouldn't screen them more than our HIV negative patients, but we need to, since we see so many metabolic disturbances in these patients, we need to be more cognizant of it. So our patients are getting older. HIV is part of the picture, but not the whole picture. And as with HIV negative patients, routine health screening will lessen the morbidity and mortality of those patients living with HIV. So complete history, make sure you yearly you stratify their risk. Inquire about smoking, alcohol, illicit drugs, sexual activity, domestic violence. Check how their support system is. And you check that annually, and or each visit, depending on the patient and the type of history that they do have. Complete physical, they should have every once a year at least. Visual screening they should have done by an eye care specialist every 6 months, especially when the CD4 count is below 100. Every 6 months they should have a dental exam. Coronary heart disease screening. Basically, you want to check, basically risk stratify them based on their risk factors, and you can do resting EKG, exercise stress test, nuclear imaging, and echocardiogram based on the risk factors there, and how far you want to go. Breast and testicular exams should be done annually. Mammogram annually after 40. Pap smear or a pelvic exam should be every 6 months. Annually after 2 consecutive negative pap smears, and they can be done using the conventional slide. Now, digital rectal exam annually after 50 years old or 45 years old with a risk, but you should check, but don't do the digital rectal exam and then check a PSA, because you can falsely elevate the PSA levels there. Anal pap smears, if men who have sex with men, or men who have or anyone who has a history of receptive anal intercourse or risk factor or previous history of HPV, you're going to want to do check this annually, and if it comes back positive, you have to refer them to anoscopy. Colon cancer screening, again, it's pretty much most of this is the same as in the HIV negative patients, but you want to check after 50 years old for colon cancer. Again, for osteoporosis, you want to consider this in all patients who have been on long-term antiviral therapy, especially in postmenopausal women or hypogonadal men. again, STD and hepatitis C screening annually, checking fasting lipids after annually after 35 years, and if they're on antiretroviral therapy, every 6 months. Checking for screening PPDs, you want to check that annually, every 6 months if they're high risk, depending on their history. And depression screening, you want to check annually. Diet and exercise, you want to every 6 months you want to see how their regimens are doing. And advanced directives, which is definitely a hot topic. As these patients get older, and going back to their support systems, who's taking care of these patients, and who's going to make the decisions should they become sick and in the hospital and need to have their wishes granted. And we talk about the vaccines that we should have. So we should get yearly influenza vaccine, pneumococcal vaccine, hepatitis B, Tdap with subsequent tetanus diphtheria every 10 years. There's literature now about HPV vaccine, which is now currently FDA approved for young women as well as young men. You do not want to give the patients the MMR vaccine if they're severely immunosuppressed, or varicella vaccine, those are live. You also want to make sure the patients have Hep A and meningococcal vaccines on board. And again, talking about the live vaccines, you don't want to give, these are the ones that these vaccines on the top here are the ones you want to avoid: the live attenuated influenza, the typhoid, smallpox vaccine, yellow fever, or the live oral polio vaccine. You can give the measles vaccine, varicella vaccine, and zoster vaccine if their CD4 is over 200, but use your clinical judgment. Thank you. All right. So how do I?